us this evening. We're pretty excited about having as many people show up this evening, and I know that's because we have a great speaker this evening going to be talking to us about intraoral radiology tips and tricks for better images. I'd first like to introduce myself. My name is Jenny Jorgensen, and I am currently the Oregon Dental Assistant Association president. And I know we have a few other board members on the screen tonight too, but I won't make them say anything unless they want to say hello. I see a few of you. Anybody have any words of wisdom to say? I'm not hearing none. Okay, well, ODAA has been really busy and we're really excited to share a few things with you. So I'm just going to spend a couple minutes before we get started talking about those things. And one of them is we have a wonderful website that we've updated that has just about every kind of information you'd want about Oregon dental assistants. And so if you are having a question about getting some training or wanting to help recruit people or whatever it might be, you're probably going to find some type of information on our website that can answer your questions. We're also connected to social media. So we have accounts on Facebook, Instagram, LinkedIn, and we currently are working on our YouTube channel as well. So take a moment to go visit when you can and see all the great things that are there. We were able to collaborate with ADEC to create a videotape about dental assistants, and dental assistants are important. That's the title of it. It's about 5 minutes long, and it features Dr. Jill Price from Portland, Oregon, where she has her general practice and her dental assistant OPID, and they talk about dental assisting and what a great profession it is. You can find that on our homepage of our website. We also have information on recruitment, and we're really looking to dental offices, dentists, dental practices to help recruit. You've got the patients in the chairs with you, so let them know that becoming a dental assistant is a great opportunity and profession. And we have a poster and a postcard that you can download and print from our website that has a QR code on it. And people can then go to our website to find out information about getting education, training, and certification. We also keep information on there about upcoming events. And just to remind everyone, March is our Dental Assistant Recognition Week, and the dates for this year are on March 2nd through the 8th. And this is a time when you can celebrate dental assistants. It's always a fun time to have extra events, maybe a lunch, a few little gifts here and there to recognize the dental assistants in your office. One of the other things coming up then in April is the Oregon Dental Conference, and it's held between April 3rd and 5th. And Oregon Dental Assistant Association has 2 courses on Friday and 1 more on Saturday morning that we're sponsoring. Plus, there's always some fun event too that we'll be doing. And we've also joined the Oregon Association of Dental Laboratories in their fall conference, and then also the Oregon Dental Hygiene Association. So you'll see us at both of those conferences from here on out too. So it's great. You'll either find CE or you'll just find us there enjoying time with some of the other professionals. We have a job posting tab. So if you're interested in posting a job or you're looking for work, we have that available on our website. We also have a new program that I just really, really love. It's called the Featured Student Program, and it's recognizing and honoring students who are either currently in a program or have just recently graduated. I think we have 4 of those right now, and their stories are so inspiring. I think it's really great to go read those stories. You'll also see them on some of our social media accounts. And of course, we have business meetings every other month. We're inviting everybody. You don't necessarily have to be a member. We'd love to have you join, but just for you to come and hear what we're doing. We're always looking for people who want to be involved and maybe have some creative ideas to help our organization and to share with us. So at any time, we'd love to see you join us. And if you have questions at all, you can always reach out, and all of our contact information is on our website. So with that being said, I'm really excited this evening to have all of you here and to be able to hear this wonderful course that Monica will present. Monica Edmonds is the Senior Region Specialist Chairside Solutions for Dentsply Sirona. Monica attended Portland Community College, Eastern Washington University, and King's College London in United Kingdom. Monica's focus is to provide professionals with current concepts, technology, and evidence-based research to assist in implementing effective and efficient evidence-based treatment protocols for clinical practice. Monica has more than 35 years clinical experience in both periodontal and general practices and 20 years of dental hygiene education. Monica was a clinical educator for Dentsply Sirona for over 6 years and served as an adjunct faculty member at Portland Community College Dental Hygiene Program. So at this moment, I would like to welcome Monica and thank you, and take it away.
Well, thank you very much for the invitation to talk with all of you this evening. I really appreciate that. We're going to talk about intraoral radiography and look at some tips and tricks for capturing better images is the topic this evening. Let's see here. So I like this image. I really like looking at these older images. We have come a long way. So this was early 1900s. So dental radiographs have not been around all that long. They've come a long way.
I'm sorry to interrupt you, Monica, but I just like for people to make sure you are muted because I can hear people in the background. It's hard then to hear Monica. So please just make sure that you are muted.
It's dinner time and family time right now. I know it's hard, so thank you for your time. So I do have to disclose to you, I am a full-time employee with Dentsply Sirona and also a shareholder. So also Dentsply Sirona cannot support or refute the non-Dentsply Sirona product claims in this presentation. So we are concerned with delivering the highest standard of care. So as dental professionals, that's our first priority with our patients, and radiographs are extremely important. So when we look at the program tonight, it's important that we understand the basic principles of paralleling and bisecting technique. We want to determine the best radiographic technique for each patient. We're going to look at some of the common radiographic errors that can occur, and then look at some techniques that we can use to minimize errors and achieve high quality diagnostic image on our first exposure. So there are some solutions for some of the challenges that we have, and they include patients that have a narrow palate or shallow palate, patients that have tori, missed apices, also getting the distal aspect of the canine on bite wing radiographs is a big challenge a lot of people have with digital sensors. So I'm not sure if you are using PSP plates. I'm not sure if any offices are using film any longer. But many offices have moved to digital radiography. So most of what I talk about tonight is going to be on digital radiography. But this is also going to include film in case you do have film, and also the PSP plates. So dental radiographs are our primary diagnostic tool to determine disease and also to come up with the appropriate treatment plan for the patient. So they should be prescribed according to the selection criteria guidelines. And these guidelines are based on a variety of factors. It includes the patient's medical and dental history, clinical signs or any symptoms of disease that the patient has. We want to look at the risk factors, how old the patient is, the age of the dentition, and also if the patient is a new patient or if this is a recare visit for the patient. They are a very valuable diagnostic tool, and so image quality is really important. We want to look at our radiographs and try to be successful when we are capturing the image, so we need to be careful with our technique and have precautions in place so that we can have enough information for that determination of the risk factors for caries or disease that the patient has. So did you know that to have a radiograph the patient actually has to have about 30 to 40% mineral loss of that tooth structure. So sometimes they're pretty far on the way. By the time, from my experience as a clinician, often we can see a lesion on a radiograph, and then when the doctor does the cavity prep, he can be quite surprised, or she can be quite surprised at how extensive the caries can be. So important that we capture that diagnostic image on our first attempt. So that's how we look at success, is acquiring that diagnostic image on our first exposure. When we are looking at our radiographs, we want images that have good detail. We want the image to be the same size as the object. We want it to also have the same shape as the object we're trying to capture. And important that it have both good density and contrast. So the different types of radiation that occur when we are capturing dental radiographs there's three types. We've got primary radiation, secondary radiation, and then scattered radiation. So primary radiation is also referred to as the central beam. It's a penetrating X-ray beam that's produced at the target of the anode, and it exits out of the tube head. And then we have that secondary radiation, and this is created when the primary beam interacts with matter, so your soft or your hard tissue, or within the skull. And then it's also less penetrating than the primary radiation. And then we have that scattered radiation. And this is a form of secondary radiation, and it results when the X-ray is deflected from its path by an interaction with matter. So a really good way to think of the different types of radiation is if you take a flashlight and you hold it up against the wall and you draw that flashlight back, and you can see some sort of distortion around the light that you have on the wall. And as you get closer and take that flashlight closer to the wall, you can see how much more clear the definition of that light from the flashlight is against the wall. So this is a good way to think about that scattered radiation, that we actually want that X-ray tube head to be right against the patient, so we're reducing that scattered radiation. And we want to think about the LARA principle. So this is really important. Always thinking about our exposure to radiation. We want to try to keep it to a minimum or as low as reasonably achievable. So this is a really nice guide that you can, it's available on many different sources. When we look at what is our recommendation for taking radiographs. So this can serve as an overview, although you really want to look at your patient individually and determine it, because depending if it's a patient of record and you know the patient's oral hygiene, you know what their history is, they have zero history of decay ever, and then you might actually think about reducing those radiographs to every 24 or 36 months. If you have somebody that presents and they have a history of caries in their mouth, or they have a restoration, we want to reevaluate that and then take them more frequently. Often, we can get into the habit of taking radiographs based on a patient's insurance coverage, and insurance coverage is really important. The cost of dentistry is expensive, but instead of looking at what does the insurance pay for, we want to look at the patient's needs so that we can actually treat the patient fairly and tailor their needs and preferences. Now, when we're talking about radiographs, an update to radiographs has been about lead aprons. So in February of 2024, we no longer have to provide a lead apron to a patient. We do need to provide a collar to a child in Oregon, and I'm a big fan of protecting our patients, because we get radiation from many different places. If you like to garden, that's a very big source of radiation that comes from the ground. If you fly a lot, you get exposed to a lot of radiation, depending on how much television you watch or how much you're spending on the screen, your screen time. Everywhere in life, radiation exists. I had a patient come to our dental office. Actually, we had a family. We had mom, dad, and they had a son. And this was a while ago, so I'm going to say probably more than 15 years ago. Mom was an attorney, dad was an engineer, and then they had this little boy. And I would ask if I could take radiographs. We had no radiographs of this child. And here he now he's like 11 years old, and I'd been seeing this boy since his first visit to the dentist office. And mom and dad didn't want radiographs either. You can no longer have a patient sign any kind of a document that says they declined radiographs, because without taking radiographs, you can't properly diagnose a patient. But we did do that. We had them sign the chart that said they wouldn't have them. And one day I walked out to the reception area to bring the little boy in. Mom had brought the child to the dentist that day, and I brought him in the back. And again, she said, no, I don't want any x-rays. And I brought him in the back and I started talking to him, and I noticed that one side of his face looked kind of enlarged or swollen. And so I put the chair back and I took a look in his mouth, and I was looking around and I couldn't see anything, any signs of swelling. His teeth all seemed very sound. He'd only lost his incisors. He hadn't lost any of his premolars yet. And so then I went back out to the reception area and I talked to the mom and I said, I just brought him in the back and I was looking around and I looked inside of his mouth and I noticed that one side of his face is larger than the other. Well, all of us are asymmetrical. We don't all have the same size, one size to the other, or eyes can be a little different, but we're not all exactly the same on the right or the left. But on him, it was noticeable. And she said, no, I hadn't noticed that. She came in the back and she looked at him. And at this time, the doctor is sitting next to me in the operatory so he can overhear this conversation. And then I said, you know, we really should take a radiograph and see what's going on here. So she agreed. And I ended up taking a Panorex image, and we saw a giant lesion that I'm not sure what was keeping his jaw from completely fracturing, but this little boy had a huge tumor in his jaw. And so he ended up having surgery and having that removed. And then, you know, he did continue to come to the dentist. And then over the next few years, I noticed that he still had this asymmetrical, but instead of the side that was larger because of the surgery, the other side of his face was developing so disproportionately. So he had some disfiguring occur on his face. But that's a really important thing to think about, is we can't see anything. You know, we don't have a crystal ball. Dental radiographs are extremely important and shouldn't be taken lightly. And so mom and dad, I didn't realize that dad actually is an engineer and knew a lot about radiation. And so he brought a device for his next appointment, and mom and dad both agreed that maybe we should go ahead and have radiographs. So I took an FMX on dad first, and he had his device that measured radiation while he was getting his x-rays taken. First off, he wanted to measure if he was actually getting any from the room next door, the operatory next door where the other hygienist was working, and he saw no movement on the needle at all. And so, you know, I know, you know, from being an educator and being a hygienist, I know that we get radiation exposure from many different sources. And so he did see that there was a very little exposure to having the radiographs I took. And so at the end of his appointment, I said, do you think that I could borrow that device from you? Because I have 3 kids and they like to sit like in front of the TV. So I took it home, and in my car, I left it on as I drove home. And boy, I could see the needle moving, going through different areas of town, intersections or whatnot. And then when I got home, I showed my kids and I put it in front of the TV and backed it up so that you could see the needle actually go down far less when we were backed up away from the television. Also standing in front of the microwave, that was another thing. They could really see how much exposure you were getting by standing in front of the microwave waiting for something to get done that you put in there. Anyway, I scarred my 2 youngest children for life because my 2 daughters do not own a TV, neither of them. The youngest one has children too, but there's no television in either of their houses, and neither one of them have a microwave either. My son was a little bit older. They're careful to not use the microwave that much. But anyway, it's just important that we think about all the areas that we're getting exposed, because it is accumulative over a lifetime. So when we look at defilm, so I know some people on here Remember using film, and when we moved from D-film to E-film, that was a big leap, going to a much faster film. And then we now have come to digital receptors. And so with digital, we are able to decrease that radiation exposure substantially. And the diagnostic image has increased at an amazing rate. Like now the new digital sensors, the last couple of years are absolutely amazing. We can see a lot more. We can capture that demineralization at a much earlier time. So while we talk about digital receptors, these can be a challenge, especially if you've had experience using film or PSP plates. Moving to digital receptors can be a big challenge. Some of the challenges are that they have a rigid case. That cord now maybe is in the way as well. And when you see this little case that I'm showing here with the sensor, we see the little dots around, and right in the middle, the yellow area, that's actually where we get our diagnostic image with a sensor. And the rest of the area around is because of the plastic casing for the sensor itself. You might have a manufacturer tell you that we don't have that dead zone on their sensors, but there's actually no way that they don't. I actually have some information where they tested all different sensors on the market and compared them with how much of a dead zone they had, one manufacturer compared with another. They all have them. And the other interesting thing is you can have the same manufacturer of the sensor and have two different sensors in your office, and they behave in a little bit different way. The case might be slightly different, or your receptor inside the case is maybe placed just slightly off, just a tiny bit, that it makes a difference. So when we look at those dotted areas on there, just keep that in mind, that we always want to be thinking about that dead zone for our sensor, and think about that with our placement. Now, if you have been a practicing clinician very long, we would always place our film or our PSP plate as close as we could to our tooth. With sensors, we're going to do something different. We're going to go where there's more real estate. So put that sensor more toward the midline of the patient, where they're going to have a little bit more room. When you get really close to the bone, when you're placing that sensor, the mouth has a lot of nerve endings in it, so it can be pretty sensitive. So we want to go more to the midline, and then remember that cotton rolls are really your friend. Another thing is, when you are getting ready to capture an image, don't say anything about a tongue to a patient, because tongues have a mind of their own. And once you say tongue, now they're invited to the party and they're going to put up a fight on and protect everything. So don't say anything about the tongue. In fact, you can actually put your sensor right on the patient's tongue, and it will act as a cushion or cotton roll for you. So just kind of forget about the tongue. Don't ever mention it to the patient, and you're going to have a much higher success capturing your image. So often, a clinician will be missing the distal of the canine when we're trying to take a bite wing x-ray. This is one of the biggest challenges that people have with the digital sensors. So you want to remember this area where we have no activity, where if the case exists, and we want to modify our technique. So here is where we would typically place it. If we had a film or a PSP plate, we would look in there because we want to capture the distal of the canine on here. And we want to get those contacts open around the premolars and the mesial of the first molar. Now with the digital sensor, we're going to exaggerate our placement a little bit. And we're actually going to try to put that entire canine on there. So when you place it, it's going to look like you're going to capture the entire canine, but you're going to be really lucky, and you're probably going to get just the distal half of that canine. So that's a little trick. And I'm going to show you how to do that a little bit later on in this presentation. And then when we're looking at periapicals, really, really important that we capture also 3 to 4 millimeters beyond the apices, because sometimes we can have a disease present there, or we have something we want to capture on the radiograph. So we want to make sure that there's enough room there that we're actually getting that on our image as well. Now, when we're talking about different devices to help us capture those diagnostic images, we have holders and we have aiming devices. So what a holder is basically just holds our PSP plate, our film, or our sensor in place, and then we have to be the person that aims it. We have to figure out how to aim it correctly. Aiming devices are actually the best way that we can capture a diagnostic image. It has a bite block, like the holder, and it also has an indicating arm and an aiming ring. These are a huge, huge help. On this particular bite block on the right, we can see this is an anterior bite block. And do you see how thick that is where the patient can bite down on that? You can get this anterior bite block either in the traditional thickness or a thicker one, like this particular image that you see here. And that's kind of a built-in cotton roll. So this is the one that I typically use all the time, because then the patient doesn't have to bite down as deeply on this particular bite block. So paralleling techniques. When we are placing our holder in the patient's mouth, we want to make sure that that receptor is placed parallel to the long axis of the tooth so that we are able to capture that diagnostic image time over time. One way to be sure of this is actually to go more to the midline, because if we hit the palate more anterior, we're going to get a bend in it. So our goal is to have it parallel with the long axis of the tooth that we can see in this image. And our beam is actually going to be perpendicular. So we want to make sure that our beam is perpendicular so we're capturing that diagnostic image. This way, if we're using an arm and a ring, we're going to have that consistency. And this is really, really important if you have a periodontally involved patient, that we can see that bone level and see what's happening each visit the patient comes. So we're actually able to get that mirror image time over time by having this practice over and over again, where we're using this true paralleling technique and we are using it perpendicular, so we're getting that consistent image. Now, these are different aiming devices and paralleling techniques that we're going to talk about today, that I'm going to present to you. And I don't know if you're able to see, can you see my arrow on here? Can you see where the arrow is? Okay, so when you are using RIN products, this is the coolest thing, and I never knew about it. As many years as I was a hygienist and a faculty, I never realized that RIN actually puts a little mark on all of their devices for bite wing, where there will be a straight line marker, either a raised piece of plastic that's a straight line right across here, or on this one, it's actually a straight line, which is a hole. This is a great cheating tool, because if you look at that and you're looking at your patient's contact, like you put the bite wing block in the patient's mouth and then have them show you their teeth so that you can see if the contacts are aligned directly or if they're shifted distal or mesial, your beam wants to go that direction. So line up this little cheat sheet line right here so that it's going to shoot straight through the contact. And then that way, if your patient's teeth are slightly rotated, you're going to have your alignment just right, so you're going to open that contact up. Now, I wish that we had this in person because I could show it to you. And if you're in an office, you can always reach out to me. I'd be happy to come by and show you some of these devices and show you that little cheat sheet line on there, because it's a pretty cool. Once you know that line's there, you'll never have an overlapping contact again when you take a bite wing radiograph. So here you can see right here where my pointer is, there's that straight line again right here on this particular bite block. Every bite block that RIN makes has some sort of a line that can help you line up your beam so it goes straight into that proximal area. And this is a cool device. This is Aura. And so with Aura, you only have to have one arm and one ring, and you can take anteriors, posteriors, and bite wings. So the traditional method would be like this, where you've got a red ring and a red sensor holder. And these are for bite wings. And then with the blue, you've got a blue ring, and then the arm will be marked blue as well, where the blue bite block sits. And if you move to Aura, you only have to have one, so less clutter in the drawer. And then you can take an FMX without having to change your arm and your ring as many times. Now, these are universal. This is XCP DS Fit. This fits every single sensor on the market. One sensor holder will fit a size 1 or 2 sensor holder. And so this is great. And then here you can see that thicker bite block on here. So you can either have it thin or thick. I prefer the thicker myself. And then again, here you can see more clearly that little cheat sheet line right here. So this would be for a vertical bite wing. Our sensor placement is different compared to our traditional bite wing. And there's that little line. So when you go to work tomorrow, take a look at your sensor holders and see if you see that little red line on them. So some of the challenges we can have are rigid bite blocks. So they've got these silicone bands on them, which make it much more comfortable to the patient. So when their palate comes down and touches the silicone bands, it kind of acts as a cushion as well. So it's much more comfortable for the patient when you're using these XCP DS Fit.
This is a video demonstration of the Dentsply Rin XCP DS Fit Universal Sensor Holder System used with the SCHIC 33 sensor. Before we demonstrate the holder, we just want to spend a few moments to help you identify your SCHIC sensor. There are a few different versions out there, and while they all work with the XCP DS Fit Universal Sensor, you might want to know which one you have. This black one here is black on the front and the back. That's the original SCHIC CDR. The next version that was released is this SCHIC CDR Elite, and now we have the very new SCHIC 33 sensor. Now, the sensor holder system from Dentsply Rin that we recommend is the XCP DS Fit. There is one bite block per indication. This blue one is for the anterior positioning, and you can see how the elastic clip just stretches out to grip that sensor securely. It's available with one bite block per indication. This yellow is the posterior. Quadrant changes are really easy. You can see how quickly I just flipped that over. There's also a horizontal bite wing and a vertical bite wing. Now, other than the fact that it's universal and autoclavable for a low cost per use, one of the other benefits of the system is that you can use a very relaxed fit sensor cover. And here is the sensor cover from Rin. It's our part number 550500. And you can see how the sensor just kind of drops all the way to the end of the cover. So we don't have to worry about pinching it into a tight sensor cover. And the holders work just on the outside of the sensor with that cover. And the benefit is when we need to remove it, the sensor basically just comes right out of the cover. You don't have to risk pulling the cord, which could potentially damage your sensor.
So that's a good point that he brought up about the sensor. The number one reason sensors fail is if you're pulling the cord out of that barrier bag, and that can cause fatigue on the cord. And these are really expensive. They can be anywhere from $3,000 to $10,000 to replace that sensor. So if you have a SCHIC sensor, one of the things they do is on the back side of the sensor, there's actually these little covers. You can take them off and replace the cord. And so that's a huge savings to the office, because then you already have a cord and we're just going to replace the cord, not the entire sensor. But this is expensive technology. So just take really good care of it. When you disinfect, wipe it. We want to wipe the sensor very gently, and don't tug and pull on the cord as you're cleaning it. So just take real good care of that and don't drop it. Anyway, so now we'll move on to bisecting the technique. So this bisecting technique, it produces a less optimal image because the receptor and the teeth are not on the same vertical plane. But it's useful in certain situations when the ideal paralleling placement cannot be achieved for your patient. So these might include a patient that has trauma, or they've got some sort of anatomical obstacle that you're not allowed to use the receptor. So it's not ideal, but you can still capture a pretty diagnostic image with this. So there's a bunch of different holders that are available for bisecting the angle technique. And these will not include an arm or a ring. Many of them do not. The one on the top does, which is really cool, because we can still now do as close as possible to a paralleling technique with the image on the top, the purple one. That's a brand new snap array that's on the marketplace for a digital sensor. And it does come with an arm and a ring. So you're not going to have as many errors with this. So if you've got a patient that maybe is reclined and you're doing an implant procedure or an endo, we also have a device, and I've got an image to show you.
This is a demonstration of the SnapArray DS universal sensor holder. Here we're going to be showing it with a SCHIC CDR sensor. This functions very similar to a regular film SnapArray, except it has cushion grips here to be very gentle for the sensor case. Basically, I'm going to first demonstrate it without a sensor cover and then show you how to use it with a sensor cover or barrier. It's very simple. You just want to put the cord between the handle here and just grip it onto the sensor. And then your sliding lock holds it in place. So you can see we have an indicating line here that lines up with the edge of the sensor to help you align it in the mouth. And these grips collapse and hold the sensor pretty firmly. Now for the anterior side, it's much like a film SnapArray. Just remember your active area is going towards the plastic, so your cord is coming out the back. And you just slide the lock towards the anterior, and then you can just hold it much like this. Now when using this with a sensor cover, here we're going to show you the RIN universal sensor cover with this sensor. What's nice about this sensor cover is it has rounded edges, so you don't get any sharp little points in the mouth. And basically what you want to do is, again, we're going to just put our cord through the handle there so we can hold on to it. And then we're going to grip the sensor. So part of the sensor is coming out at the bottom. That's not where we want it at first, but let me show you why we do that. Now once you have the sensor gripped like that, you can press the sensor up, and the slack is going to come out of your sensor cover or barrier towards the bottom. So now your grips are holding the bag tight against this top edge, so you don't have to worry about it sliding out. And there you go. That's all you have to do. Nice firm grip. And the same thing with the interior. Again, very easy and fast loading. And you can see this edge right here can be used as an incisal guide when you're doing your interior imaging. And it's completely universal. This is shown with the SCHIC CDR, but it works with any sensor. You can see if you have the newer CDR Elite, holds it very easily.
So these are really helpful, really helpful. And the image here on the right, this is for a patient, this cutout area right here. If you're doing an implant or an endo treatment and you want to make sure you've got the file correct or you've got your implant placed correctly, patient maybe is lying down, you can still use your arm and your ring. So these are the little marks here that we can use to put our arm into, and then we can use the ring, and we're not going to get a cone cut because it's really hard when your patient is in a supine position to be able to capture that diagnostic image. And then for the anterior, when he was talking about this, sometimes you might have a patient that maybe they don't have teeth on the opposing arch. And so this holder can come in really handy if you have to have the patient hold it for you. And you can still use the arm and the ring as well. And this is how it would look with the arm and the ring. So you're still able, you've got this option. If you've got a shallow palate, you have this particular option here on the right. And you can see how this arm fits right into these little grooves. You can still use the arm and the ring. The other thing that he showed was this purple indicating line right here. So you don't have to make a guess if I'm going to capture the sensor. If you're not using the arm and the ring, this comes in really handy for you to be able to orient yourself to be able to capture a diagnostic image and not get a giant cone cut, because this will show you exactly where that digital sensor is. Just have the patient show you their teeth, have them smile once it's in place, and then you're able to use that little line right there to help you get a diagnostic image. Now the bisecting technique, sometimes you have to do this. Sometimes you have a patient where you just have no option. They've got a shallow palate. You're not able to actually use the true paralleling technique. So what you want to do is you want to place your receptor on that, and it's going to be as parallel as we can get it to the long axis of the tooth. And then you're going to kind of let it gently set where it is. So here we can see where the tooth is this yellow line, and where the sensor holder, or sensor, excuse me, lines up. Really, now we know it's not perfect. It's not parallel with the long axis. So we're going to come up with an imaginary line right here, where we're going to bisect that central beam. So what we're going to do now is we're just going to kind of imagine where that line is, and that's where we're going to try to deflect our image. So the primary beam is directed perpendicular to that imaginary line, and that's called bisecting the angle. So here we can see when we're bisecting the angle, our target is this imaginary line right here. In reality, this patient has a very shallow palate, so it's really the only way we can capture a diagnostic image. This is actually truly ideal, but we can't get that, so this is going to give us a diagnostic image. Now, this is going to show you the bisecting the technique video.
This session is going to describe what bisecting.
And I just have to tell you one thing. I'm going to back up a little bit because I love these ladies. They're two dental assisting instructors in Pennsylvania. And if you ever want to look at some videos, if you're struggling with capturing a diagnostic image, you can go to YouTube and look for RIN. And then these two ladies have made a series of videos that are incredibly helpful. And they're so cute as well, but they're very well experienced dental assisting instructors. So I put their video in here.
This session is going to describe what bisecting angle is and actually how to use it. Many offices actually use the ring instruments, which helps with the bisecting angle because it's doing all the work for you. What happens is when you reuse a ring and the film slants in the mouth, the bar is exactly telling you exactly what angle to use for that purpose. Using the rings eliminates the elongation, foreshortening, and overlapping. A lot of offices do not use this ring. They use the actual bisecting angle technique. And what is that actually? I'll kind of explain it a little bit on this little diagram here. Ideally, what you want to get is the correct length of the tooth image on your film. And to do this, you have to use the correct vertical tube angle when you're projecting the x-ray at the tooth. Too much vertical tube angle, not enough, is going to cause the error of elongation and foreshortening. So how do you eliminate this? Basically what bisecting angle is, and where that term angle bisecting comes from, is determined by the placement of the film in the mouth and the long axis of the tooth. So if you look at the two of them, you are forming an angle. Now, because of this angle here, what you want to do is actually bring your vertical tube or your cone, your x-ray beam up enough so that as it travels out, it's going to cross what we call the bisected line. And what is the bisected line? Well, actually what it's doing is actually bisecting this angle. You draw an imaginary line between the film, the long axis of the tooth, and here's that imaginary line. And ideally, when you place it in the mouth, and if everything's in position like this, you start bringing your vertical tube up. So as the beam travels out of the cone, it's going to cross the bisected line at a perpendicular or right angle. And by doing so, that causes the image of the tooth to be exactly the right size on your film itself. It's when you don't have the correct angle, you're too high or too low, that your image is going to be too short. Like as you raise this up higher and higher, if it was projected down in this position, what happens is the root tip gets projected down here, and that causes a real short little image. If you don't have enough angle, see this arrow here is where you should be. Let's say you're coming in like this and don't increase it enough. What happens is the x-rays travel in a straight line. This root tip is projected on your film way up here, and that gives you your elongated image. So ideally what you need to do is set the vertical tube angle yourself to project the correct length of the tooth. Some offices have sensors only, and I'm going to show you how to use the sensor and bisecting angle. It's pretty much similar to the other film or PSP plates, but sometimes you run into a few other problems with it. First of all, when you place it in the mouth, it is bigger and bulkier, and a lot of times when it is in the mouth, I'm going to turn it this way so you can see, the sensor itself is going to hit the roof of the mouth and pull out like so, which is going to distort your image, and and it even comes out of the piece once in a while. So what you want to do then is when you place it in the mouth, tip it slightly so that the patient can actually reach the bite block more easily, and that won't occur. By pulling like this, you're going to have a distorted image by losing the root tips or the bottom edge of the teeth also because of this. So better with the bisecting angle is to turn everything and increase your tube angle because of that, then try to have them bite hard and do this. So let's just put this in and show how much easier this is too with this holder. Again, we'll do the upper premolars. So I'm going to slant it like so, retract the cheek out, slide it in, and have them gently close. Okay, when I say gently, until her teeth are actually on the apparatus itself. So it's perfect like that. Adjust the head so that the occlusal plane is horizontal to the floor, and then you'll take your x-ray tube, and if you can actually see the angle of the film or sensor in the mouth, that will, again, you're going to bring this up to determine the angle of the sensor, the long axis of the tooth, and about halfway is where you're going to guide your x-ray beam to be perpendicular to this. Kind of a close guide to this is if you can see your sensor and the position of that in the mouth, if you just about bring your cone up to meet at a right angle to the film and maybe bring it back a couple degrees, then you will be actually crossing that bisected line. So this will work out great like this. Bottom edge covering the sensor, side of it covering the front edge, and there's this, which is nice on these particular pieces here, there's this little purple line, you can see that? That's indicating where the front edge of your sensor is in the mouth. So if you actually take this cone and bring it right to this line, this purple line, you won't be missing the front edge of the sensor.
So that's really helpful. And they've got a whole series of videos. They're great. So again, this is showing you how she does bisecting the angle. And then again, this is the one with a cutout that you can use for endo treatment or implant treatment. And you can use an arm and a ring with it as well. So now looking at our bite wings, because of the digital sensors and we've got that diminished area, you might have to use vertical bite wings now to be able to capture more of what you're trying to get on your image. So we see a lot of offices moving from just doing 4 horizontal bite wings to maybe now doing 6 vertical bite wings. So they're able to actually cover more diagnostic information that they need to diagnose any kind of disease for the patient. There's bite wing tabs, and these can be more comfortable for the patient. It means that you need to be very, very careful with your placement. Always think about trying to have your patient's bite parallel with the occlusal plane of the floor. If you're trying to just wing it, sometimes people think that the arms and the rings are training wheels. They're not actually. Dental x-rays are so incredibly important that they're meant to help you get that true diagnostic image time over time. But you might have a patient where you have to use just a paper tab because the patient just cannot tolerate having a sensor holder in their mouth. So then these are available. And now this is another device. Boy, I wish I had invented this because this is the coolest thing ever. Dental assistants love this device. It's called the Unigrip 360. You just take one bite block and you can take an FMX. It's almost like playing with a Lego. So this little tab, I have a video to show you as well. You just slide this up here, further up on here, and then you turn it and swap this around, and you've got it ready for an anterior PA. Right now we're posterior PA. When you slide it up to the middle, it's ready for a posterior bite wing. So it's a really, really cool device, does have an arm and a ring. So for those patients who just don't have room in their mouth to accommodate a sensor holder, this is the coolest thing. Most of the offices I know that have this will have a combination. I have a couple of offices, this is the only device they use for dental radiographs, but most offices will have these and also the traditional arms and rings and bite block holders. So here we can see it's an anterior position. So it's the same one. You can just play with it. When I do a hands-on, I bring Hershey's chocolate, the little Hershey's chocolate, and we'll pretend those are sensors, and we use one of these Unigrip 360s so you can see how it works, and it's fantastic. So now here's the video on it.
One of the main benefits of the Unigrip 360 is that it comes with relaxed fit sensor covers. You don't need to use a tight cover with this adhesive holder. Tight covers can increase the chance for sensor damage, as users have to use more force to get the sensor out of the cover. To apply the Unigrip 360, just remove the liner and place it on the center of the sensor active area with the smaller legs by the cord. Wrap the side arms first to secure the sensor, and then, pinching the sensor cover close to the cord, apply the bottom legs. It's very adaptable. It can use with any sensor that you use. It's very lightweight. In fact, a lot of people just use this by itself for the bite wings because it's light and it's less bulk for those people with narrow mouths. It does come with an autoclavable ring system, which has the colors, the red for the bite wing, the yellow for the posteriors, and the blue for the anteriors. Let's start with the bite wings. I'm just going to clip it on here. I'm going to have the patient open her mouth and put it on the second molar and have her patient bite down. I'd bring my cone in and line it up, and then I'd be able to take my x-ray. Now for the premolar view for the bite wings, what we want to make sure to include is the distal of the canine right here. So because of the sensor is bulky, we want to get it toward the middle of the patient's mouth, making sure that it is parallel, bringing it up so I can see that the canine is going to be projected on there, and have the patient bite down again and sliding that up. Now you would just do that for the opposite side for the double bite wings. Now I'll take it out of her mouth and we'll do the anteriors. Switching to the anteriors, all you have to do is bring this tab, put it into the middle, and then bring it down to the blue line. But because I'm doing the anterior, I don't want to have the red, I want to have the blue. So I'll flip it over, and so that the circle encompasses the bite wing. I'm going to put it in her mouth and just have her bite down. If it tips like that, all you need is a cotton roll to straighten it out. Some people's teeth are a little pointy. Okay, bite down now for me. And that way you can get a good image.
Isn't that just the coolest device? I think a dental assistant must have invented this because it is just so slick. You can take an FMX in like half the time because you're not changing out the bite block. You're just making the rotation like she did. So it's a really, really cool device. So let's talk about some common errors that we can have. So often our common errors can be our placement. So if we don't place it correctly, it's going to cause us some problems. I'm going to show you how to get the distal of the canine. We've got a little kind of trick you can use. We also have our vertical angulation, horizontal, and then is our x-ray beam centered. So when we look at this next image here, I'm going to show you the bite wing troubleshooting. So on the left image, it shows the ideal placement. So when it's possible to put your sensor here, or your PSP plate. It's really easy with PSP plates or film, but with a sensor, it can be a challenge if you have somebody that is really narrow or they've got tori or it's just a challenge to get it there. So there's a technique called open the door. And so what we're going to do is we're actually going to go across the arch because we want to be able to get that canine captured on this sensor. So this is called opening the door. Now, when you're making this modification, this is the one time when you're not going to be looking at your arm. So once you go over here, we know our open contacts are right here. We can see, we can have the patient smile and show us our teeth and we can see the contact. And in this case, we're going to use our eye and direct the beam straight on to our sensor. In this situation, we're truly parallel, the one on the left, but the image on the right, we're making a modification. If you've not done this technique before and you do it, it's going to feel awkward to you. You're going to think, wow, I'm going to get all these anterior teeth. You really aren't, because remember that dead zone that I showed you on a sensor in the beginning of the program? This is going to help compensate for that. So this is what it will look like, because you're actually directing your beam straight in between the contact. The ring is helping us to make sure we're not getting a cone cut, but we're going to disregard being parallel with that arm. In most cases, we would be, but when we're doing the open door technique to capture the distal of the canine, then we want to maybe think outside the circle. Now our horizontal angulation, it's almost like you get a mental block. If you take a radiograph and you can immediately see that the contacts are closed, then you're going to take another one and son of a gun, you did great on all the patients you had so far today, open contacts. Now this one, you got a closed contact, you took a retake, you got a closed contact again. You can get a mental block about it. So what we want to do is really, maybe you have to look in the patient's mouth, like have them open and look to see, is there a rotation in the molars where they're actually not straight aligned as we're used to. And we want to be thinking about how we can direct our beam straight into those interproximal areas so that we open those proximal areas up. This vertical angulation, she talked about this a little bit in her video. So if we are over angulating, we're going to have these circus teeth. So we've got them shortened. So we want to drop it back down and place it correctly so that our central beam is going perpendicular to the tooth so we can capture that diagnostic image. And this was the other extreme that she talked about. If we're creating the circus teeth now that are elongated. So this is not a good distortion to have either. So again, the red arrow is showing what we did and how we capture that image. You want to come back up and straighten that out. And that's where the arms and the rings can be really helpful. And again, remember, we want 3 to 4 millimeters. So this image is fine for looking for caries, but we're not getting all of the information that we need to capture on a radiograph when it's a periapical. So there's some special considerations for patients. So for some of the patients that gag, we want to make sure that we are all set for that. So there's a lot of different distraction techniques that you can use. One that I often use is I'll tell a patient you have to hold up one foot and you can't place it on top of the other one to hold it up in the air. You actually need to hold it up in the air. And this is a distraction technique for them because now they're thinking about their foot, so they're not gagging. I've had some people tell me that they have a clothespin in their drawer and they'll put it on the patient's ear. So now the patient's thinking about this clothespin on their ear. Another thing that I've done is some of the salt dispensers that you get at fast food places. I'll keep some of those packets in my drawer, and then I'll give the patient one of those packets and have them put salt on the tip of their tongue. Just put it in the palm of their hand and then just lick it, and then they've got the salt taste on the tip of their tongue. That works really well. Another thing you can do is have them rinse with some Listerine. That works great as well. And if you have any other suggestions, do share them, because it is really frustrating when you've got a patient that gags a lot. For patients with a shallow palate, remember to move where there's more real estate in the patient's mouth. Go to the midline where there's a little bit more area in there. And then just let that sensor find its own place in there. Don't mention the tongue at all to the patient. Really important if you've got patients with a tori, you might be using their tongue as a cotton roll where you just place it right there. If it's not comfortable to the patient, they're going to subconsciously pull their tongue back, but often the tongue can be a real big help. And for tori, you might have to move further back into the patient's mouth to be able to capture the image you're trying to get. Now, if you have a patient with a really narrow arch, again, you're going to have to go as far lingual as you possibly can with your sensor holder. You might have to use a size 1, something that's a little bit smaller than you would actually prefer, but it might be your only way to get a diagnostic image on that patient that has a narrow arch. So this can be a real challenge. So in this situation, what I would do is I would probably actually go behind the tori, so be placing pretty far back in the patient's mouth. Behind that tori, we wouldn't actually be putting our sensor holder right on that tori. We'd need to go further back. And the same in this situation. So I've actually had patients before where those mandibular tori are actually touching. And so we can't get anything in there. That's going to become incredibly uncomfortable to the patient. So you're going to have to go further back into the patient's mouth. And now how do we improve patients' comfort? Again, the midline. So go where there's more real estate. The other thing is so important to just say, instead of saying close to your patient after you place it, what you want to do is when you're capturing an image, when you put your sensor in the patient's mouth, touch the teeth first and have the opposing arch come down to meet it. If you're putting the sensor in and then you tell the patient close or gently close, you're going to wind up leaving it to chance. We're going to wind up with more mandible or more maxilla. But in order to have those bite wings evenly distributed, so you've got enough of the maxillary teeth and the mandibular teeth, touch the tooth. And the same way with a PA, touch the tooth, the one that you want to capture the image of that tooth, touch that tooth with the sensor holder, and then say slowly close versus close or bite. Say the word slowly first, because if you say close first and then slowly, it's too late. They've already closed down. And you maybe haven't had a chance to move or move the cord out of the way as well. Distraction techniques, again, those are fantastic. Salt, raise your foot, have the patient rinse with Listerine, and then cotton rolls. Cotton rolls are your friend. They can be very, very helpful to you. And then switching from a size 2 to a size 1. So for PA troubleshooting, we talked about shallow and narrow palates. Move to a smaller sensor and use those comfort aids. And we talked about cotton rolls. Let the sensor find its place in the mouth and then adjust the angulation if you've got somebody with a really narrow palate and you're just really struggling on how you're going to get a diagnostic image. Again, that bisecting technique can be very helpful for those patients. If you have missed apices on those occlusal edges, you want to make sure that you touch the teeth you want to capture the image on, touch that with the sensor holder, and then make sure you're doing a true parallel technique using your arm and your ring to help you capture those. And we talked about tori already using comfort aids. And then the bisecting. So you might have to kind of do a pseudo bisecting angle. So try paralleling first, allow that sensor to find its place in the mouth, and then adjust your angulation so that the sensor and the tube head are parallel. And then you can back off of your angulation just a little bit. So you might teach yourself that when you are maybe using your arm and your ring to teach yourself so you can actually understand how that's going to work. And then tackle the true bisecting the angle technique without the arm and the ring. So overlapping teeth, make sure you've got those proximal surfaces opened up. So look for those little cheating areas, that straight line that's on your bite wing holders, and that's going to be your angle. So line it up with your contact area so that you're getting that X-ray beam directed directly into that proximal surfaces. And then it might be easier if you need to get the patient, if you can't use an arm and a ring, make sure that your patient's bite is parallel with the occlusal plane is parallel with the floor, and then adjust your vertical angulation at 5 to 10 degrees when you're gonna kind of freestyle it. Here's a map of the mouth, and I will email that out so that if you would like it, this can be really, really helpful to help you with your receptor placement. So this is a great way. You've got a little star that shows you where you're going to direct your central beam. So this is a great little tool to have. And I've got another kind of summary that I did, and I like to hand this out. Excuse me. And it's just kind of a recap, just a real quick one-sheet notes that kind of go over paralleling technique and the principles of it, how to direct the beam. Using a comfort wand is another device that I usually bring with me. And then just some of the high points about bisecting the angle as well. So I will email both this chart and this tips and tricks little list that I have so that if you want access to it, I'll make sure that I get that to you. So final thoughts, we want to maximize that diagnostic value. We want to think about our patient protection, think about our parallel technique and keeping our patients comfortable. We want our diagnostic image on that first try, so success indeed. And then success on our first attempt. Do modifications for your techniques if they're required. And we want to minimize our errors using our parallel techniques and aiming devices. So anybody have any questions? I see there's a couple things in the chat. I'm not sure if they're a question.
I have a question.
Okay,
Yeah.
do you see the question in the chat, Monica?
Let's see here.
There was a couple of advice ones.
Oh, we've been using a product called No Gag. It's a powder that tricks them into thinking that they're eating. Oh, I'll have to look that up. That's great. And then somebody said, we call this cross arch. Oh, Peggy said that. Open the door. Hi, Peggy. I know Peggy. And then regarding sensor sizes, when you say size 2 versus size 1, is one size meant for children versus adults? Often it is. The size 1 is smaller, although I know some dentists will use a size 2 on children unless they're really small, because they're just, you're going to get more information off of a larger sensor versus a smaller one. But yes, that's what we're talking about. Often it's referred to as a pedo or a smaller sensor holder. Anybody else have a question?
I do.
Hi, Sandy.
Hi. So do we still recommend wearing the lead apron taken panoramics? Because I've been hearing different things.
Well, when you look at, I'm a fan of lead only because I have traveled a lot and I garden and I know how much radiation we're getting exposed to. So according to, the experts on radiation protection, the lowest amount of exposure you're getting is dental radiographs, the lowest. And so we no longer have to use the apron. When you're talking about a panoramic image, the amount of exposure that a patient's getting is actually reduced. It's less than an FMX. So I think people, you kind of have to, I think, often talk to your patient. If your patient wants an apron, give them an apron. If you're comfortable with giving it, which I am, I'm going to still continue to offer. If I have a patient that says, no, I don't need it, then I'm fine. Okay. But for children, we do want to provide that collar because thyroid cancer is on the rise, higher numbers than ever. And actually all cancers are. So, but according to the ADA, we no longer, and the Oregon Board of Dentistry says we no longer have to provide a lead apron or shielding to adult patients any longer.
Okay, perfect. So bottom line, just always offer it, period. Just say, hey, would you like to wear it? Yeah, that's what we do. Okay, just wanted to confirm that. Thank you.
Yeah, you're welcome. Any other questions?
I think there's one that says why rectangular columnation is considered to be better.
Oh, because of that scattered radiation, that secondary radiation. If you're doing rectangular collimation, so what the American Council on Radiation Protection said, this is where it all kind of started with the lead apron, is that it still says that. You can go online and look at the information. They said if you're using digital sensors now, so we've reduced that radiation exposure, we've decreased it substantially over film, and then you're using rectangular collimation, then you don't need a lead apron. So when you look at rectangular collimation, it really is, you've got to be very precise. And I would never imagine trying to take a radiograph with a rectangular collimator and not using an arm and a ring. So when you look at some of the RIN products, the arms that'll have a square rectangular cutout, that's for a rectangular collimator to line right up with that arm, or that, excuse me, that ring, so that you can be that precise. And so really that is the recommendation. I know some offices are using it. There's a lot of different devices out there in the marketplace. Some, I would try them before you buy them, because some of them are heavier. So for the patient who has a sensitive mouth, and now you're putting the digital sensor in there, and it's a metal collimator, it's going to be heavier for the patient and uncomfortable. But it is what is recommended from the National Council on Radiation Protection and Safety. They do recommend rectangular collimation. And I think we're going to see more of it moving forward.
I think there's one other question. Do you see that one? I know that we kind of covered this, but just to clarify, I know that the ADA recommendations are to not put a lead apron on a patient, but this is the operator's choice to provide it then?
That's the ADA. So you can go to the ADA, just go to the website and you can pull that down and take a look at it. And it just says that they no longer recommend it or require a lead apron. So for dental radiographs, and that's what it says on their website. So it's up to what the dentist recommends. We work under their umbrella. You know, we work for a dentist, and I know a lot of times people say, well, I don't want to do the apron because it's heavy, or it's going to take a few extra minutes to put it on and take it off and disinfect it. So according to the American Dental Association, we are not required to use a lead apron with patients.
Monica, I'm just curious, is this the same recommendation if you're using like D-speed film, or is that just
Oh my
for
gosh.
digital?
Oh, you know what? That's a really good question. Is anybody still using D-film
Well, we use it when we're teaching.
when you're teaching on typhodonts, right? On mannequins,
Yes.
on Dexters. Yeah, so when you're doing Dexters, you know, I would get students in the habit, if they do happen to go to an office that's still using film, there's the difference between the amount of radiation that you're getting from a film versus a digital sensor is substantial.
Right. Yeah, we use both. We just do the conventional because it teaches infection control and
For
mounting.
sure, which is incredibly important. It's number one. So there's mixed feelings. I have my own opinion, and I probably shouldn't bring my opinion when you're teaching a class. It's hard not to. But when I go to the dentist, I ask for a lead apron. So for me personally, but I know my lifestyle, you know, and anytime I can be outside in the dirt or traveling or whatever I do. So, you know, we're exposed to so many things in life. You know, it's just, you need to feel comfortable about what you're doing, you know, and if I had trouble sleeping at night because I all of a sudden wasn't offering people, and that's how I am. If all of a sudden I didn't offer them a lead apron anymore or give them the option, I think it would bother me personally, just because it's ingrained in my soul, you know.
Yeah. Any other questions? Doesn't look like it, but there's thank yous in there, and I definitely want to thank Monica for presenting this evening. This was great. I think, gosh, a lot of tips and ideas, and you're an amazing presenter, so thank you very much for coming this evening.
Thank you so much, and thank you for attending and giving me a little bit of your evening. And I will send out those resources. I'll email those to you, and then
Okay.
you can share them if they'd like to have them.
Okay, sounds great.
All right. Thank you.
Okay,
Thank you so much.
thank you, everyone. Have a good
Yeah.
rest of your evening.
Yeah, and if anybody wants to reach out to me too, I can put up my
Okay,
contact
yeah,
information.
her information is up here too. So for those of you that want to write this down before we go. Okay. All right, everyone. Thank you. Have a good rest of your evening.
Have a nice
Bye-bye.
evening.
Thanks,
Bye-bye.
Monica.
Bye-bye.